Hello, my name is Faraj, and I'm a professor of nutrition at University of Montreal and at the IRCM, and I'll be presenting on why targeting hyperapoB with hypocaloric diet reduces the risk for type 2 diabetes in subjects with obesity. HyperapoB is elevated number of atherogenic particles in the circulation, which are the particles that carry mainly cholesterol and triglycerides. Whether in the fasting or a postprandial state, each of these lipoproteins have only one ApoB, as one ApoB 100 in the fasting particles, LDL, IDL, and VLDL. After a postprandial meal, you also have lipids circulating on chylomicron, which has ApoB 48. Therefore, the measure of plasma ApoB is the number of these particles, and a hyperapoB is mainly a reflection of elevated number of LDL in the circulation because most of these particles exist as LDL. Now, we know that elevated atherogenic particles are related to atherosclerosis, of course, and the development of multiple inflammatory reaction in the body. However, if we take plasma LDL cholesterol, it is not associated with plasma inflammatory markers as shown by many clinical studies. In 2006, we took the number of these particles rather than their cholesterol content, and we showed that indeed plasma ApoB is a predictor of inflammatory status in postmenopausal overweight and obese women. Now, hyperapoB is a known dyslipoproteinemia that promotes cardiovascular death in subjects with type 2 diabetes. And we had just shown that ApoB is a predictor of inflammatory status. And we all know that, like cardiovascular disease, type 2 diabetes is an inflammatory disease. Therefore, we developed the hypothesis that hyperapoB is a promoter and not a mere consequence of type 2 diabetes in humans. Luckily, this did not remain as a hypothesis, as multiple epidemiological studies came later after in many populations like Turkish, Canadian, Finnish, and Korean, showing that plasma ApoB is indeed a predictor of the incidence of type 2 diabetes, and that's 3 to 10 years before its onset, despite multiple and independent of multiple risk factors, including inflammation and even plasma glucose. And so there must be a mechanism that is linking ApoB, mostly LDL, to the risk factors for type 2 diabetes in human, and that's what we started to examine. Now, we focused our attention on adipose tissue function because we know it's related to maintaining glucose and lipid homeostasis in human, especially after a high-fat meal. After a high-fat meal, lipids circulate in the form of chylomicron, and for the triglycerides to be cleared, it has to be hydrolyzed by the activity of lipoprotein lipase on adipose tissue, taken up and stored in adipose tissue. In the case of a dysfunctional adipose tissue, lipoprotein lipase activity is reduced, and so is the hydrolysis, uptake, and storage of this chylomicron in the adipose tissue. Now, of course, lipid will accumulate in the circulation, leading to postprandial hyper-TG, and lipids will go to all other peripheral tissue, like the liver, pancreas, and muscle, which are not equipped for this high amount of lipids, which induces lipotoxicity in these tissue. Lipotoxicity is a known promoter of insulin resistance and the hyperinsulinemia that counterbalance insulin resistance in humans, and therefore the development of risk factors for type 2 diabetes. In the liver, lipotoxicity also induces the secretion of ApoB lipoprotein particles accumulating in the form of LDL in the circulation. Now, we wanted to know whether now LDL go back and act directly on adipose tissue, inducing its dysfunction and therefore promoting all these risk factors for type 2 diabetes in subjects with hyperapoB. To examine that, we developed a clinical trial with a 6-month hypocaloric diet intervention in subjects with overweight and obesity. This trial was registered and all the data is already published in baseline and post-intervention data. We recruited between 2010 and 2013, 81 subjects, middle age with a higher BMI, overweight and obesity. They were sedentary, non-smoker with low alcohol. But other than that, they had no other cardiometabolic disease or drugs affecting metabolism, including, of course, they were non-diabetic. How did we measure adipose tissue function? The first hypothesis examined whether plasma ApoB was positive and associated with white adipose tissue dysfunction and risk factor for type 2 diabetes in this population. Now, adipose tissue function was examined by synthesizing chylomicron in the lab, which is really a synthetic lipoprotein rich in radioactive triglycerides. If adipose tissue is functional, then it has to hydrolyze, take up, and store the lipid substrate as HT-labeled lipids, and there will be less fatty acids released in the circulation. Now we see when we add this substrate on the adipose tissue of our subjects that the higher the ApoB, the lower there is adipose tissue function in these subjects. And this is sex independent because there was no difference between men and women as shown here. If these subjects also have delayed, if they have dysfunctional adipose tissue, then they would be expected to have postprandial hyper-TG. And indeed, we gave the subjects a high-fat meal where the lipids were labeled with stable isotope C13-triolene, and we followed their clearance in the circulation. And we see that subjects with high ApoB have delayed postprandial total triglyceride as well as the triglycerides that were coming from the meal that they were labeled. We also measured insulin secretion and sensitivity in this population by using the Botnia clamp, which is really a gold standard for these measurements. By infusing glucose, intravenous glucose, we see an increased rise in the glucose, and for that, the body will respond by increasing secretion of insulin. By measuring the area under the curve of plasma insulin the first 10 minutes and the last 50 minutes during the IVCT, this is what we use as a measure for insulin secretion for the first phase and the second phase and the total. We then raise plasma insulin to supraphysiological level, and we counterbalance with a glucose infusion with the aim of reducing plasma glucose back to baseline level of about 5. And the higher the subject can tolerate glucose infusion, the higher they have insulin sensitivity. But what you see here is also as hypothesized is that the higher the plasma ApoB, the higher there is glucose-induced insulin secretion during the IVCT, and the lower is the insulin sensitivity during the hyperinsulinemic clamp. So indeed, subjects with high ApoB have dysfunctional adipose tissue, postprandial hyper-TG, increased insulin secretion, and reduced insulin sensitivity. The second part of the hypothesis was hypothesis 2. We tested whether plasma ApoB was associated with a better response to the 6-month hypercaloric diet to reduce the risk of type 2 diabetes in subjects with overweight and obesity. Out of the 81 subjects recruited, 59 completed the study, and the intervention did induce a reduction in the total energy intake, BMI, together with the fat mass. However, there was a large variation in the response after the intervention. What you see here is the 59 subjects who completed the intervention, and still in this smaller population, plasma ApoB is related to higher second phase total insulin secretion and a reduction in insulin sensitivity. And plasma ApoB was also associated with a better response after the hypocaloric diet, as the higher the ApoB, the lower there was a reduction, the more there was a reduction in first phase, second phase, and total insulin secretion, and the higher the insulin sensitivity. What's happening on the adipose tissue level in those subpopulation where we took the adipose tissue biopsies from them, we see that in this smaller population of 25 from the original population, plasma ApoB was associated with a reduction in adipose tissue in baseline, as we saw in the total population, but now there is also an increase in adipose tissue function after the intervention in people with high ApoB. We further separated the population into low and high ApoB around medium ApoB, and we saw that it's only subjects with high ApoB who had an increase in adipose tissue function by about 100%, despite equal amount of weight loss and energy intake and expenditure in this population. And it was also the same subject with high ApoB who had the greatest response in the reduction of insulin secretion after the intervention. Now, by what mechanism may LBL be promoting adipose tissue dysfunction? For that, we looked at the activity of lipoprotein lipase. We incubated purified lipoprotein lipase with the synthetic particles that we synthesize in the plasma. We call it synthetic lipoprotein with radioactive TG. And we see that LDL, physiological concentration of LDL, inhibit the activity of lipoprotein lipase in a dose-dependent manner. Now, if we take adipose tissue of the subjects and do the same incubated without LDL, with the presence of the radioactive triglyceride or radioactive chylomicron, synthetic chylomicron, we see that addition of LDL over the incubation time of 4 hours reduces the amount of triglycerides taken up and stored in adipose tissue and increase the amount of fatty acid that is remaining in the medium. Now we further looked at the function of adipocytes and specifically and how would that be affected by LDL, both using murine and human adipocyte, SGB as shown here. Normally, the adipocytes will decrease in number as they differentiate and increase in lipid accumulation, of course, which is the main feature of adipocyte differentiation. What we see here is that physiological concentration of LDL reverses that. LDL increases the number of adipocytes during differentiation and reduce their lipid accumulation in reverse to what would happen when you don't have LDL. And this is even using very small concentrations starting at 0.2 where you have almost a plateau. LDL also reduces the hydrolysis uptake and storage of the synthetic chylomicron or adipocyte function, and it's also at a very low concentration. It reaches a plateau of 0.2. We further looked at the gene expression machinery of the adipocyte during their differentiation. And as would be expected, LDL reduces the expression of genes related to differentiation, lipid accumulation and adipogenesis, as well as glucose and insulin sensitivity, but increases the expression of genes related to inflammation. Particularly shown here is the MCP1, monocyte chemoattractive protein, which increases the migration of monocytes into adipose tissue, inducing adipose tissue inflammation and promotion of adipose tissue dysfunction. You may ask, how is that related to in vivo function of adipose tissue? Adipose tissue does not last forever in human. Every 10 years, the 100% of the adipocyte die and get replaced by differentiating adipocytes. So you can imagine that if differentiation is suboptimal, then the adipose tissue that will result after differentiation will be dysfunctional, therefore promoting the risk factors for type 2 diabetes in women. Therefore, in subjects with overweight and obesity, we've shown that hyperapoB identified those at the highest risk for developing type 2 diabetes because elevated plasma ApoB, mostly in the form of LDL, induces white adipose tissue dysfunction and related risk factors for type 2 diabetes. And that's likely by decreasing adipocyte differentiation and function, and it's increasing in inflammation, as we shown in the human model of adipocytes. We also showed that reducing hyperapoB with hypercaloric diet reduces the risk for type 2 diabetes because it improves white adipose tissue dysfunction and related risk factors, mostly insulin secretion. So what would that mean is that targeting subjects with hyperapoB would increase the benefit of the hypocaloric diet to reduce the risk of type 2 diabetes in a population of overweight and obesity. Now, currently we're looking at further mechanism that LDL will increase the dysfunction of adipocytes, and that's through looking at its effect on a special innate immunity pathway, the NLRP3 inflammasome, and how LDL may activate this system, increasing the secretion of interleukin beta. And all this system is related to type 2 diabetes and cardiovascular disease. So by that, we look at how LDL may be inducing the dysfunction of adipose tissue by increasing the activation of the system in the macrophage resident in adipose tissue. We also look at how omega-3 fatty acid may be counterbalancing the effect of LDL, therefore providing a treatment, a natural treatment for these subjects, even without weight loss. This clinical trial is completed and closed, and the results are currently under publication, so hopefully stay tuned, they will be coming out soon. Finally, I would like to acknowledge the great work of the team of the lab who had produced all these data, whether the past team who have all moved on to great future right now, or to those who are currently involved in the research projects in the lab. I'd like to acknowledge the incredible collaboration of the IRCM physicians who help us in the recruitment and in the biopsies of the subjects, those who are present, who are unfortunately departed us, Dr. Dufour and Davignon, and acknowledge the collaboration of our colleagues nationally and internationally, both on a fundamental and clinical level. I also acknowledge the research institute that we belong to, as well as the funding agency for the support of our work. And I thank you for your attention.